So in this video, we're just going to briefly overview different supraventricular arrhythmias, because overall they have different key 12-lead and lead to ECG characteristics. In addition, this will help lead to your management priorities and treatments. And there's a couple of them that we look at. So the first one is sinus tachycardia. We obviously don't have to overview that. We all know what that is. Again, sinus tachycardia isn't pathological. It's just indicative of a compensatory response, whether it's from a pulmonary embolism, whether it's from sepsis, whether you're experiencing hemorrhage in a trauma, and now you're compensating for this insult. If we look at atrial flutter, though, this has a couple key similarities to atrial fibrillation. Both have an increased risk of clots, especially the longer they've been in, and the incidence goes up as we get older. Because a large risk factor for patients going in atrial flutter is cardiovascular disease, underlying hypertension, cardiomyopathies, increased risk of age, once again. So that can lead to a risk of patients going to atrial flutter. But there is key differences from atrial fibrillation. So if we examine our normal conduction pathway once again, impulse should come from the SA node, go down to the AV node, that slows down there. Then it gets distributed to the bundle branches and out to the Purkinje fibers. However, in atrial flutter, normally there's enhanced automaticity or that reentry pattern because of cardiac ischemia once again. And usually the impulse occurs, or the irregular foci comes from by the tricuspid valve. So just above it, so obviously that's why it's called atrial flutter. And usually it travels in a counterclockwise fashion. And some of the impulses get conducted to the AV node and subsequently gets propagated to the rest of the myocardium. But if we look, this is why it manifests with this sawtooth pattern. So this represents that the atria are depolarizing and contracting. However, the atria can fire at 250 to 300 beats per minute and creating this sawtooth pattern. But the key difference with atrial flutter in comparison to atrial fibrillation is usually the R to R waves are regular in atrial flutter. That's not an absolute, but normally they are, because the AV node has a refractory period, a longer one, so it allows for impulses to be conducted down there normally. Again, you can't conduct when a tissue's in its absolute refractory period. So this is why you can have different conduction rates in atrial flutter. So this is a 2-to-1 ratio. So you have 2 atrial contraction for every 1 QRS segment or ventricular contraction. You can also have 3-to-1. You can have 4-to-1. But overall, the atria are firing here, and then it's getting through the AV node because it's out of its refractory period and subsequently being distributed down to the ventricles. But this is the sawtooth pattern that it typically manifests in atrial flutter in comparison to atrial fibrillation. It has that multiple ectopic foci going on in the atria, and some of the impulses only get conducted through the AV node, but that's why it's so irregular. And if we look at the 12-lead, you can tell and distinguish atrial flutter by looking at the inferior leads, especially if the impulses are going in a counterclockwise fashion. You usually have inverted sawtooth pattern in the inferior leads, and if you look at V1, you'll have an upright P wave. That is highly indicative of atrial flutter, and again, it's the impulses or reentry current is traveling in a counterclockwise fashion. And again, these QRS segments are regular. So that's kind of the key differences. And again, usually atrial flutter is caused by ischemia. This leads to irritable myocardial cells, which overall changes their properties, and this leads to the reentry circuit, especially if you get a premature atrial contraction that conducts at the right time, and then it gets caught in that reentry pattern going in a counterclockwise fashion, which subsequently manifests on the 12-lead and lead to as a sawtooth pattern. In comparison, we look at Wolff-Parkinson-White syndrome. So this is for patients that have an accessory pathway. So we look at the heart again. Again, impulses should come from the SA node, traveling down to the AV node, down to the bundle branches and Purkinje fibers. However, in Wolff-Parkinson-White, they have an accessory pathway. About 50% of the time is usually on the left side of the heart. Sometimes it can happen over here in other areas too. But if we have an accessory pathway, that means an impulse can travel from the SA node and bypass the AV node, then start to go down the accessory pathway and prematurely activates the ventricles. Sometimes too, impulses can travel down from the SA node to the AV node and simultaneously through the accessory pathway, but because this doesn't have any properties for the impulses to slow down in comparison to the AV node, that'll start to pre-excite the ventricles before it will over here. So this is why the typical kind of patterns for Wolff-Parkinson-White syndrome, there's some variations to it and that go beyond the scope of this short video, but normally you have a shortened PR interval and this delta wave, which is this upslope of the QRS segment. And that's highly indicative that the ventricles are already being prematurely excited because of the accessory pathway, which is the bundle of Kent. And this one doesn't have a wide QRS, but again, sometimes they do manifest with a wide QRS and that upslope in the QRS segment because it's prematurely exciting the ventricles because it's using the accessory pathway. So part of the treatment plan, if it's indicated for patients, can be an ablation. So you burn this area away so you cannot conduct impulses down the accessory pathway. However, a certain population or subset of the population, about 20 to 30%, can manifest in atrial fibrillation with Wolff-Parkinson-White syndrome. So that is highly problematic because that's why it's contraindication, that atrial fibrillation is a contraindication for adenosine administration because it's an AV node blocker. So it slows the impulses through the AV node, hopefully interrupts the reentry current, which should be given for those patients in supraventricular tachycardia and not atrial flutter, atrial fibrillation, or sinus tachycardia. Because what if the patient has Wolff-Parkinson-White and they're in atrial fibrillation? This can obviously lead to multiple ectopic foci going on in the atria, and some are getting through the AV node down to the ventricles, but others are going through the actual accessory pathway. And again, if we slow the impulses down through the AV node, that would slow down that heart rate. But again, you have the atria contracting at 300 to 500 beats per minute in atrial fibrillation. And then now they don't slow down in this area and they can just conduct and conduct and conduct down this accessory pathway that prematurely excites the ventricles. And this could lead to ventricular fibrillation. So this could be a potentially deadly consequence if adenosine is given to someone with Wolff-Parkinson-White syndrome and atrial fibrillation. But that's why it's good to recognize these ECG patterns and the overall pathophysiology of it. Furthermore, the last one is supraventricular tachycardia. So obviously, we have to recognize if they're stable versus unstable. Stable, they have their GCS 15, their lungs are clear, their blood pressure is in normal ranges, they look like they're perfusing still, so we can give them the Valsalva maneuver and or adenosine. If unstable, they have altered GCS, ongoing chest pain, hypotension, cyanosis, are they modeled, and just overall low blood pressure, cannot get a blood pressure. Unstable. But here you can see that there's so many different causes of supraventricular tachycardia. So supra means the impulse is coming above the ventricles. That's why it's a narrow QRS, unless they have an underlying bundle branch as well too. But that goes beyond this video. There's so many different causes of SVT. It could be medications, could be caffeine, could be smoking. They could be in a kind of thyroid storm. They could have electrolyte imbalances. They could overall have underlying heart disease. But overall, it's a regular rhythm because the impulse is coming from the same spot in the atria. You can't distinguish if this is a T wave or a P wave, but you have a narrow QRS, so again, you know it's coming from the atria and above the ventricles. That's why it's supraventricular tachycardia. And it's regular because it's coming from the same spot. So if we look, it doesn't have the sawtooth pattern. Again, you can't differentiate if that's a T wave or a P wave. It's quick. It's usually over 150 beats per minute. Some sinus tachycardias can manifest over 150 beats per minute, but the key way to distinguish that is that there would be a P wave and a T wave that is undeniably seen on the ECG pattern. So this is a supraventricular tachycardia because, again, no identifiable P wave. Can't tell if that's a T wave or vice versa, and it's quick. So that's a pathological rhythm. And again, we have all those different causes, and patients can be in SVT for hours potentially before they decompensate, but that's obviously not advised to be in that rhythm for that long. So overall, this video is just to differentiate the different supraventricular arrhythmias, how we could treat them, and the risks and benefits to different treatment plans.